Good afternoon. We will now call this special work session for September 20th to order, and I will hand it over to Deputy Superintendent Wayne Green.
Thank you, Madam Chair. For this special session, we're going to be doing a health plan renewal, and we have here with us Linda King, our Senior Director for Risk Management and Employee Benefits.
Thank you, Deputy Superintendent Green and Chair Mrs. Wyatt and fellow board members. Thank you for the opportunity to come today and give you an update on the health plan. And with me today as my guest is Jan Bush, the district's benefits consultant. I think you all know Jan. And so the first thing we're going to talk about today really is that's fivefold, and we thought this would be a good overview for you. The last time we were here was March when we did an update on the district's financials and where we were for the certification of the health plan. So today, this is what we're going to cover. We'll talk about current strategies, the projections that have been updated through August 1st of where we are financially, and then strategy considerations. And another important piece that Mr. Hyde had asked me to bring forward to you too was school district comparisons, looking at the top 10 school boards, of which we're number 7 now. I never thought we'd pass my home of Pinellas County, but we have. And then I'm looking for feedback from you today or additional questions of what you would like us to bring back to you. Okay, health plan projections, just to give you an update, as a reminder, we ended 2022 at $7 million. The premium revenue you see reflected here of $126 million, actually, it includes a $45 board increase per member per month, per employee per month, excuse me, that we actually added to the health fund beginning July 1.
And just to clarify, it was the 2021 December 31 balance?
Yes.
So we started January
Yeah.
1st of 2022 with a surplus of $7 million, but that did include a $10 million transfer from COVID funds.
Do we have that slide? Oh, I'm sorry. I'm on it right now. There we are. It's the third, yeah, it's the third slide, sorry. Oh, okay.
No.
There we go, thank you.
So, and other revenue is going to include things such as, rebates and other guarantees that we have based on our contract with Blue Cross Blue Shield. And that's shown there. So total revenue was $134 million projected in 2022. Incurred claims, we're at $126.8 million. We talked about this, about the health plan, and to be honest, the health plan reflects the health of your employees and the group that's enrolled here. So that's what you're going to see playing out here. Other expenses, $12 million for a total expense of $139 million. So we're projected to end the year at a loss of $4.8 million. So we're already starting to trick a little bit down from what we had anticipated. But again, that's based on the revenue currently coming in and the expenses. And then 2023, we have a projection here. Jan, do you want to cover
Sure.
the projections for 23 and 24?
So these are all projections, right? Because we are still in the middle of 2022. So if these assumptions that the actuary uses were to hold true, we would end 2022 with a balance of $2.2 million in the group insurance fund. So we bring that forward into 2023. And again, the only revenue change we show here is the $45 per employee per month board increase. So we're looking at revenue going to $137 million. Your claims are trended forward, so you can see that your claims expense looks like it could go to $139 million. So your total expenses would be going to $151 million. Yes.
And tell me, that's quite a jump. When you look at historical data prior to 2002, was there a huge jump in the incurred claims from 2021 to 22, which made you increase them substantially for 23?
They did go up substantially.
Did they? Okay.
And when we look at things on a per member per month basis, so adjusts for the number of people who are on the plan at any given time. So if you have more people, you'd expect the whole dollars to be greater, but when you divide that by more people, it's not as big of a, of a unit impact. But I looked at from 2019,
Yes.
PMPM, just on the claims expense side,
Sure.
where we were in 2019 to year-to-date in 2022, the medical claims and pharmacy claims expense has gone up 41%, PMPM. So that's a pretty significant increase in your expenses going on in the plan. So if the assumptions, again, hold true for 2023, we would be looking at losing $14 million. We take that off of our $2.2 million surplus balance, if you will, as of January 1st, and we're pretty much in the hole by $12 million.
I just have a question. That 41% is from 2019 to 2022 or 2019 to 2020?
2019 to 2022. So we looked at
Okay.
what the PMPM was in 2019 and what the PMPM was through May of 2022,
Right.
and it's a 41% increase.
Do you show an annual trend? instead
Yeah,
of that
and
space?
we do look at annual trend, and you're running fairly high, but the actuarial projection was 8%,
Okay.
which was fairly hopeful, I would say, hopeful, based on what's happening. And, you know, we come to you every year when we do the state actuarial filing, and for the last several years, we've really been hoping upon hope that, you know, we wouldn't be having the large claim activity that we're having. We just have some very unfortunate cases within the group, and 2022 is no exception to what we have been seeing. So the impact of those large claims has really, again, had a tremendous impact. Coupled with a lot of chronic conditions. So we've got a lot of diabetes, a lot of cardiovascular. COVID was not a, you know, that's the long hauler. You know, we don't know what the impact long-term is going to be for what COVID has dealt society. So, so it should, you know, again, it's chronic conditions plus those acute issues that are driving the costs in the plan. And people are using the health centers too. So, so that's been a successful strategy to get people in to try to manage their health care. It's just, there's just quite a demand for services. So 2023 is not good news, but without any changes for 2024, and again, that's only assumed in 2023, that $45 increase, but 2024 is significantly worse. If nothing were to happen between now and 2024, January 1st, it would be very problematic for the health plan, and it wouldn't be able to be certified as being actuarially sound from the standpoint of what the state's looking at. So, so that's kind of the bad news there. And again, when you don't have the balance, it's just having to come out of funds. You know, the money's having to come from somewhere to pay those claims. So the district is picking those, you know, those expenses up, you know, when they get invoiced for the cost of healthcare services every month from Florida Blue, it's having to come out of the funds that the district has available. Any questions on that? And I feel like I'm the bearer of terrible, bad news. But we've been, you know, in our last couple of sessions that we've been here, we've kind of painted that picture that things were not going well and not, and after, as of March, when we were here, we said this, you know, it looks a little bit better today because the district put in $45 more. So it doesn't look like the loss that we were looking at in March. But that's, you know, again, revenue that's coming in from the board effective July 1st. Any questions on that?
Okay, well, just as a reminder, some of the current, oh, I'm sorry, Mr. Allen?
Yeah, indeed.
Dr. Allen?
No worries. Going back to March, probably, I know we, it's just a very small amount, but we invested in the Embold
Yes.
system. And just recalling on that, it was the first year that we're in right now, correct? 2022 is a $450,000 investment with a one-to-one guaranteed, was what I remember in regards to claim reduction. And then in 2023, and is that factoring into this? So we then are increasing our investment in that data tool to 750 with the 2-to-1 is what the contract had noted and guaranteed. Do you see any impact from that investment in the Embold system? And can you demonstrate any metrics or anything like that in the value of what that contract and that software enabled for us?
Yeah, we do have a projected performance guarantee from Embold. This first year was focusing on health center referrals, and so far we are hearing good things. The other good news is that I met with Watson Clinic, and they've got a new quality initiative, some new administrative heads now that are really focused on quality. And so it was a good discussion, and the discussion is continuing. So it seemed timely for them that we're bringing that forward. Obviously, what we're looking to do is build relationships and improve the network across Polk, which ultimately will save us money and savings and avoid that wasted medical dollar that so often is out there, and then employees feel dissatisfied. They, can't get answers to what's going on with them. So actually in August, or June rather, the health center had the largest referral process, the largest number of referrals in the history of Embold so far. Like over, I think it was over 500 or more referrals.
It's a double-edged sword statement. I'm just
It was, it's a pretty young company, but they were, with the marketing we had done some magnets and some different things, but the training we've done with Everside, that they were very impressed with the number of referrals and hits off the network, with their network for referrals. So I think we're just starting, right? This is just the start of this. The other plan that we'll talk about, a future strategy, was to lower the copayment, for that, which will be a part of what we propose to discuss with the union as far as bargaining, as obviously everything we do with our plan has got to be negotiated. So that is the plan, and we were hoping to do something mid-year, but we'll talk through those. But yes, so far some good things, but that's going to be more of a long-term, it'll take us several years,
Sure.
obviously, to see the fruit from that. So yes.
Great, thank you.
So current strategies, as you know, we're self-funded. We use Florida Blue, the network of Florida Blue. They do have a large provider network in Central Florida, and we do have performance guarantees as a part of that. We have medical management for complex and chronic conditions. We also use Teladoc still for virtual care. That's not behavioral health, but just physical health. And then we had Wonder Health that was rolled out this year. Now, this number's a little low, but this was an initial projection. We had 4,600 pounds lost in 6 months. We got some feedback from our members, and all in all, very positive as far as they were so appreciative of the benefit. They felt that they had a tool now to put them more in control of their eating. They also saw a reduction in their stress level, sleeping better, and they were thankful that the tool was provided to them at no cost. So I think that's, and they're waiting, and the interest in the program continues. So we'll be setting up, actually, we're going to set up a special class just for those new employees starting November 1. So that's been very, very good. We had over almost 17,000 employees participate in that. So that was very successful. We continue to have great interest, as Jan said, in our employee health centers. No member cost. Our return on investment there is like 2.27 to 1, just because of the cost and what we're able to offer through the center, the economies of scale, compared to what's offered in the community. And we do primary and acute care. We have switched to an appointment-only process because of COVID. And so we've seen more people continuing to use that more as a medical home, which, to be honest, is kind of the way we want to go with that, to use it as a medical home for primary care, focusing on wellness, chronic condition management, coaching. We do offer physical, occupational, massage therapy there, medical massage. We do on-site behavioral health with a counselor that we have there. And the Embold process is being driven through our providers, through that center right now. So the 2023 return on investment guarantee there is 2-to-1. In addition, we have the ABCs of Diabetes program, where we have about 600 participants, and they get free covered medications and supplies with that. The wellness programs and incentives have been just getting started over the last couple of years. We do a health risk assessment and biometric screenings through Florida Blue. We have hypertension, hyperlipidemia, and an on-site dietitian through Everside Health through our systems and offerings there. The Employee Assistance Program is through Aetna, and it's Resources for Living. We continue to see increased use there, obviously, as that need has grown. They help with depression, anxiety resources. They have a program called My Strength, which is, on an app, so you can access that. They offer financial and legal services and information on work-life balance through that program. Now, I'm sorry, yes, Ms. Miller.
Costs for all of the programs that you mentioned, these preventative programs, what's the district's cost for those programs?
Well, they're all rolled in the total cost of the $125 million program that we have. They're all premiums that are paid for that. As far as you mean for the employee or for the school
What's our
board?
cost to offer those free
cost?
to our employees?
It's based on each and every contract provider, and a lot of those have been renegotiated. Jan, do you have more detail on that?
Well, let's come back with that, because I think it's a really good question.
I would be interested in how much of all these separate programs that we're investing
Yeah.
in,
Yeah.
Sure.
for the number of participation compared to the number of people we employ, I'm just concerned with that cost.
Right,
Okay.
so, the cost of the ABC's diabetes, the cost of the hypertension programs, and the HRA, and I think that's
Yeah.
And can you provide the number of employees that are enrolled and actively enrolled? Do we count people who sign up for that program or someone who finishes that program? How are you counting those people?
which program are you?
Just like the diabetic program or the hypertension or the,
Yeah.
I believe it's a quarterly picture as far as the numbers, as far as who participates, because people come in and come out based on, they have to meet certain requirements. So if they don't meet requirements, they're given some time to get caught up on that, and if they don't meet it, then they are dropped, and then they have to come back in.
I just want to know the cost factor, because plenty of people sign up for programs they may attend once or twice. The benefit of the prescription medication for people who have diabetes, I think, is, I would like to see the numbers on that. I'm just curious of the investment.
Absolutely, absolutely. It's not tied to outcomes or changes in A1C, for instance, your hemoglobin A1C results, so it's not an outcome-based program. It is based on education and certain requirements that are in the program. And we're going to talk a little bit about the ABC's program and some potential options to try to drive back to the use of generics and be able to take advantage of some of the manufacturer couponing that's occurring in a lot of those diabetes medications that you hear about every evening on the TV. So, and they are great drugs, don't get me wrong. They're just extremely expensive. So, so we'll talk about that. But the district actually pays Everside a staffing cost. So it's basically two wellness people, two people who are the health coaches, Jordan and Jasmine, if you may know them, and also a dietitian, Ashley. So those are the three individuals who are really pretty much dedicated to the wellness program, so that would also be encompassing of the hypertension and the hyperlipidemia programs, as well as the ABC's a diabetes program. And, one of the things we're really kind of stepping back and looking at is how do we free them up from certain things that they're spending time doing to do more things out in the schools and in the locations where there's concentrations of people, to try to, create that health awareness and help people understand what's available to them and how there are resources to try to help have optimal health outcomes. So really, right now, it's the cost of the staffing and then the cost of the incentive, which is basically providing free medications to, for generics and brand medications, as well as the continuous glucose monitors and supplies that go along with your diabetes management. But we'll come back with some costs. So, good question.
Okay, and some other strategy considerations that we're certainly looking at too would be One was a plan design option, developing like a base plan or a buy-up structure where employees could still have a base plan at a 0 premium and buy up to perhaps something that looked like the current plan, and including an employee premium. When we looked at the revenue that's generated, obviously doesn't include any employee dollars other than for family coverage. We're looking at another program as well, Surgery Plus, that a lot of school boards have used. And would be a voluntary benefit for ambulatory surgery, but it would look at outcomes and savings. And, it's another program, Ms. Miller, that we could bring back to show you what that cost savings is projected to be and anticipated enrollment, too, for that. We're also.
Do you have a current enrollment for that, or just?
No, this would be a future, so
A
it's just a
future program.
projection,
Okay.
yes. It's just another way for employees to save money by getting things pre-approved and going through different providers.
Yeah, that includes a navigator. It's called Surgery Plus, and it's a network of ambulatory surgery facilities that if your doctor says you need to have an outpatient surgery, that you would potentially be able to, first you would contact a navigator who would kind of start that intake and engagement and kind of trying to understand what have you done and, in terms of conservative treatment, have you tried physical therapy, have you done some other types of interventions that might preclude you from even having to have surgery. And then if you do end up being a surgical candidate, you're directed to these centers of excellence, if you will, that they have negotiated. And it's not just about the negotiated fee, their outcomes, that they don't have the complication rates for certain things. So it's been around for several years, and the return on investment or savings potential is really based upon how much utilization you get. So a big part of it is getting the word out. If you need surgery, contact this number, call this number, talk to someone who might be able to help you save money. Because the groups that have this, and you can set the cost share however you want, but most consider it to be a free benefit for people to use those providers. And there's also a travel benefit. So if you do have to travel outside of the area, there would be some reimbursement for mileage, for hotel, for, things to be able to utilize that network. Yes.
The question I have is if your doctor in Lakeland at Watson Clinic says you need surgery and this sends you to Brandon, is it connected? I don't know. I don't know anybody that uses these services. How would our employees navigate the rest of their care? Do you know what I mean? Like, a lot of people don't do surgery outside of their centers or outside because it's all connected.
Right. So this, again, would be a voluntary option for
understand.
employees to be able to, if your doctor's recommending surgery, to contact the navigator, if you will, the liaison who could kind of understand what your issues are, where you're contemplating the surgery. Some may be recommending a place that is already in the Surgery Plus network, but when they're facilitating that, they're actually going to be involved from the very beginning to the end. And in addition to just kind of helping with the clinical aspects of it, if you were, for instance, to get a balance bill or to get some other kind of information from your provider that you didn't feel quite right about, your navigator intervenes on your behalf as well. But a similar concept with Embold. The more savings that you're going to be able to potentially realize is based on how much people actually use it. So education, communication is really key to helping people understand what benefits are available and how to use them.
We also had talked to Surgery Plus, too, about the Embold network to make sure that we're aligning right with that as well. If that was something we were going to be exploring, we wanted to make sure that, it was also how it compares to the Embold ratings for their centers of excellence or their preferred network. So we also are looking at Blue Cross Blue Shield. Florida Blue this year is offering for the first time a program to help manage specialty drugs, and that's going to be offered for self-insured groups beginning in January of 2023. And it really is just going to help us better manage those costs and help save costs through the pharmacy benefit manager, which is Prime Therapeutics.
And these are actually drugs that get dispensed outside of the pharmacy benefit. These are medical specialties. So
Yes.
if you have to have Remicade, for instance, or an infusion that at your doctor's office, these are medical specialty medications. And so an estimated savings was more than $500,000 on that. So, again, it's being able to, leverage the manufacturer incentives that are out there to try to promote their medications.
And then I mentioned earlier the reduced co-payment for enrolled designated providers we were looking at as well. As something to just encourage, that was a second-year strategy to help drive more utilization, obviously, of the enrolled network. And it would be a subset of the current enrolled network. So one thing we'll be definitely looking at is how that's going to affect access to care and volume of care too, and to make sure that employees will have the access they need. Depending on the number of providers that meet a certain score per se. And Embold would work with us on a designated directory that would help drive that and say this is at this copayment. So when you pull up the directory, it would exactly show you what the copayment would be for that particular doctor. So the concern is as we pare down that cost, looking at how that affects network access as well. So one of the strategy considerations that we're definitely looking at, and Ms. Miller, this leads into your cost and the number of people participating, is looking at modifying the ABCs of Diabetes program. It's pretty much almost been the same since 2012, 2014. As Jan mentioned, as new pharmaceutical commercials have come out, we've continued to offer the latest, greatest brand name. If it's medically called for, if it will help the employee control, like a lot of them attack different types of system problems as diabetes continues to roll on, like heart and kidney and some of those other areas as well. So we continue to offer that at no cost. And one of the concerns that I have is we're not getting access to all of the big pharma money out there as far as the coupon programs. The school board's plan is not enjoying that money coming back in the way the current program is structured. So that's pretty easy if you restructure that to allow yourself to get the coupon. Right now, some employees are getting access to that are not in ABC's program. But the ones that are in ABC's are basically getting it at zero cost, so they're not really engaged in the coupon process because there's not a cost. So because of that, we're not enjoying that savings. So what we were looking at doing with the adjusted pharmacy was really to look at free covered and getting back to the heart of the program, to be honest, when it first rolled out was free generic medications. And there weren't a lot of other pharmaceuticals available out there for diabetes. But as the program evolved, really those additional brands were not, I guess, looked at.
The brand had a half copay. So
copay.
back before 2012, there were free generics, and then which included 3 therapeutic classes. So there was the diabetes, hypertension, and hyperlipidemia cholesterol classes. So those were free generics because a lot of diabetics have those medications on a regular basis. Brands were half copay. So if the copay was $50 for someone enrolled in ABCs, it was $25 for the brand. And then in 2012, the decision was made to remove all cost share. And since then, a lot of the very expensive, wonderful drugs have come out on the market, and it's just becoming very, very expensive to maintain.
So we were looking at going back to the original intent was like a half copayment incentive for the program. And then we were looking at a $100 copayment for continuous glucose monitors as well. Currently, again, those are at no cost for people that it's prescribed on, and that tends to be very expensive as well. And then we were also looking and working closer with Everside Health. A lot of the ABC's members go through Everside, obviously directly for this, through the coaching, and they're also seeing an Everside physician. So we're looking at a closed formulary with them directly with prescriptions, and the pricing has become much more attractive. We did look at this a couple of years ago, but the pricing at that time was pretty close to what we were spending with Prime under our Blue Cross network, but the pricing has actually come down a little bit. So there were a number of things that looked like they would be, if we carved them out, for example, from our program, that we look like we'd end up saving saving some money on those
Yeah,
pharmaceuticals.
and we'll be
for-
coming back with some numbers relative to that. It's really just to kind of get feedback on the ABC's program in general. Does it seem like
Correct.
it's time to revisit that program and come back with some, some potential changes in the incentive for that program? But still, this scenario, if you will, still provides the opportunity for the free brand medications dispensed at the health centers.
Yeah.
So, and what RX Solutions basically, or Total RX, is coming back with is basically saying we can take advantage of all those manufacturer coupons
Correct.
on the back end. So that would be, again, a big savings to the plan. What we would give up in rebates that we get through the pharmacy benefit manager, we would make up in the manufacturer incentives.
Yes.
And
we're
then
also-
I'm sorry, go ahead.
That's all right. Well, the other part of this, too, is we were doing an analysis, because, Everside gets all the data from Blue Cross Blue Shield, and we're finding that a number of the people in the ABCs or Diabetes program have multiple prescriptions from multiple providers. And so the concern is taking a look at that and providing some sort of pharmacy review for them to see if all that is really working the way it should. Because at this point, if they're using multiple providers and multiple scripts, is that really indeed necessary for them? Is it getting the best for them, or can there be some economies of scale with cutting back on some of those drugs, and maybe some of them are contradictive to one another? And the concern is the average employee may not understand that. They're just going to the doctor and they're taking what the doctor's prescribed. But the concern is it's causing a tremendous amount of cost, and we don't know really from a therapeutic side if it's really doing what's intended for the program.
And that's that polypharmacy. When you see that word polypharmacy, it's
Yeah.
basically those people that are on 5 or more medications. And it's pharmacist-driven, so it's kind of looking at all the different clinical aspects of indications, counterindications that Linda was mentioning as well.
And also, as Jan said too, we have really 3 employees primarily that are pretty much dedicated just to the diabetic program. And what I would really like to see us do is offer some other ways of managing that program so that we could make those resources available district-wide and get out more to work on the pre-diabetics, get out more to schools, get out more with some other programs too that are actually taking those people that are gradually getting worse and hoping to curtail, some of that and improve the health overall, the entire population, rather than just focusing on a very small percentage of our population. It's basically more disease management, to be honest, what's happening now, rather than what I'd like to see, which would be more overall wellness and improvement of quality of life. And some of the other things we can do for our employees to encourage that and to create more of a structured program, which is similar. As we look at some of the other districts, that's what a lot of the other districts have found success with, is using those resources for those types of programs over for the entire district.
Because you've got only 1/3 of your diabetics in the ABCs of Diabetes program, so that means you've got a lot of other diabetics who are, having to try to manage their situations with their providers, or maybe not even at all. So, so I think, as, Linda mentioned, having something scalable that could reach more people using digital technology now, in a conjunction with other technology, seems to be the direction that there's been better successes with. And, the CGM technology is really a very, it's a very sound way of understanding how your behavior impacts your glucose levels. And so that's become an emerging it's been out there a while, but there's just a lot more discussion around diabetes reversal, if you will, or remission, some people call it. But, again, being able to understand those triggers that cause certain things to occur help you change a behavior that might otherwise cause you to have a less favorable outcome.
Yes, ma'am.
Can you tell me how many of our employees are currently using it, and how many retirees? Is there any way to track that and know that?
I don't
Because
have
it
the,
used to be a very popular program.
yeah, it fluctuates, but we have about 600 members. I would have to bring back the breakdown of that, how many are actively, the under 65 retirees versus active. employees. We could also have dependents on there as well, spouses, dependent children
That
as
would
well.
be good to know. If you can provide that, I'd appreciate it.
Okay. Absolutely, we can bring that back to you. Some other strategy considerations that we see a need for is definitely expanding something to the behavioral health. And this is more from a teledoc format. We're not currently paying for this, so this would be an increase in cost, but we really see the need for more behavioral health. And with the pandemic, a lot of people got very comfortable with teledoc and remote counseling especially. So we see that as a need that we think can really help. As well, dermatology seems to be kind of a limited practice where people do have some time it takes sometimes to get in for appointments. So we also thought about adding that as well for the screenings that are necessary. We're also evaluating additional community healthcare providers for use by employees as additional access points of care. So we're looking to see what can help fill a niche that we may have, and so we'll be bringing that back to you as well. We're also considering releasing an RFP in 2023. Our current Blue Cross Florida Blue contract is good through the end of 2023, so it renew 2024. So we're considering releasing an RFP. We do know that Polk has been more expensive. You know, we're not like the Tampa market and the Orlando market where healthcare has tended to be more expensive in the central part of the state. But we do know we have additional competition coming in, so that's a good thing for us. We've got Advent's already here. I know Central Florida Healthcare is, Central Florida Hospital is coming in. And also HCA Hospital has a couple proposals out there as well. So we think the increase in competition definitely will be helpful. What I don't know is what appetite there may be out there for some more creative plan designs. You know, one district I was watching closely was Osceola Schools. They pretty much threw out their entire program and they built it from scratch. It's a lot of work. They also ended up with a very narrow network. You're going to see that when we talk about some of the other districts. Some of the other districts' strategies have been to offer more of a scaled-down plan as the free plan and offer opportunities for employees to buy up at different options, which Polk, you'll see, has been the only one offering one plan for a number of years. You'll see that when we move forward with that. But so we're wondering if there's any innovative solutions out there. Another thing is reference-based pricing, where you go out and you negotiate. But it may mean that maybe we only get part of the network in there and not all of it. But these are definitely strategies that we can go out there and talk to our partners about and see what appetite there is in Polk County to maybe do something different. So that was the plan in 2023. Historically, we have not been out to bid for some time. Jan remembers the history on that. I wasn't here yet, but we have not been, just because it's been more difficult in the Polk County market. As I said, Publix has Florida Blue, as well as a lot of the other large employers over Florida Blue. And again, that is really about the network and the access to care in Polk County. So,
And keeping in mind, 95 cents out of every dollar is going to direct health care. It's not going to pay the administrator of your plan.
Yeah.
So it's a well-run plan from the standpoint of where the dollars are going. People who might have chronic conditions are still going to have chronic conditions, whether it's Aetna paying the claims or Blue Cross or United Healthcare or someone else. So, I think coupled with a strategy of how to help people know where good healthcare services and be good healthcare consumers is something that's got to continue to be a strategy that continues to be reinforced.
Another thing that we looked at too is that we are the only district we have an 8-tier rate structure. In my 30-year career, I've never had an 8-tier rate structure.
You're my only client with an 8-tier rate.
I'm your only client with that, yes. Most of the districts you'll see have a 4-tier, 3-tier. 3-tier is a little more aggressive, and to be honest, I used to be with a smaller district that had 2-tier, so just employee or family. That was a little tough, but One thing I would like to consider would be a 4-tiered premium structure. And this just gives you an idea, if you look at this slide, this gives you an idea of what the current membership is, and also what the premium we're charging, and then what the true cost is. Now, obviously, you know, for people like retirees, you're never gonna charge enough, right? Because when they're under 65 and they're in that group, that tends to be your higher cost, right? So you're never really gonna charge enough. But if you see here, what's really telling is that our spouse cost, look how high our spouse cost is. And even our children cost, the cost of what we're paying in premium for children is significantly lower than what the true cost is to administer. And that tends to be your cheaper cost there are children on your plan. And I understand kind of the strategy behind why the district did what they did for more single parents and concern over providing some sort of health insurance option to your members, your employees. But at the same time, it has not grown over time, and it continues to quote, be subsidized basically by your employer dollars is what's happening. Which is a concern. And that price of over $100, I was paying like 25 years ago when I bought a single policy for my child. So that is a concern, to take a look at that and maybe come somewhere in the middle with that. Okay, here's some potential savings that, again, we're assuming very conservatively here. Surgery Plus, we're assuming like a 15% use if we were to put that navigation program in place, and that would be a little over $1 million in savings. The SmartX for our medical specialty drugs would be nearly $1 million in savings. And then if we went with total RX closed formulary, we would be a little over $500,000 in savings with those strategies, which takes us to about 2.6, which is great, but it's not going to get us towards that $4 million deficit that we are expected to experience in 2023. It's just all these things, as you're saying, Ms. Miller and Ms. Cunningham, all these little strategies that we could look at for doing what's best in class right now, what a lot of our districts are doing, and a lot of our districts are struggling with the very same issue we're struggling with today, which is the increase in cost. And, trying to provide an excellent benefit and strategy for your employees. Yes, ma'am.
You had mentioned putting this out as an RFP. Do you think we'll see great difference in what we get, or is it going to be
the
similar?
problem is it's our people, right? So it really depends.
Are you saying we have less healthy people than Publix?
I would say overall, your strategy, my concern is, Ms. Miller, that our benefit design is what a lot of companies used in 1990. So that's the concern, is the plan design really has not gone through substantial changes in some time. And I understand why you did that again. You were struggling to pay salaries. But at some times, it comes out of the same pot of money, but salaries and benefits. So, as a struggle is to pay people more, how do we balance? And I think offering, something that's a little more aligned to our current partners. I mean, we're still offering a free health center that has over 90% demand, and that's a wonderful benefit. I can tell you that is a huge attraction. And some of our neighbors, Osceola is doing it. I think a couple of the others have picked on it, but we're the only one. Hillsboro's not offering a free health center. So there are still points that make you very competitive. But I really think, to be honest, that the strategy overall, of course, Publix doesn't have unions, so they put plans in place and changes gradually. And they are doing a lot of these things to look at improving, but they've already got a lot of these, co-pays and other things in place for their members.
I appreciate you looking at our competitors, and I don't know what the other larger companies in Polk County offer, but I would like to see, we're second now largest employer in the county.
Yep.
To look at what the top 5 large employers are doing, I think that would be beneficial. So at least we can explain that when we're talking to our employees.
And I'll certainly see, private employers aren't always quite too willing to share their benefit strategy, but I have had some conversations with Publix, so perhaps they'd be willing to share some of their plan design information with us. So, yes, ma'am.
Well, I think even on that note, some of our other municipalities and
Uh-huh.
the county, just because a lot of our positions overlap,
Yes.
especially as we're looking for things like CDLs and maintenance, those types of positions. Beyond that, I know a couple of years ago, we did an audit of who was on our plan and making
Yes.
sure that we got any spouses that were no longer spouses or kids that had aged out, those types of things off of our plan. How did that go? Where did we complete that? Is that something that we should be doing on a regular basis?
Well, we did save a tremendous amount of money off doing that project. I'm trying to remember the total. Jan, do you remember the total? We'd have to look back at that, but we did get that straightened out, so to speak. And I am making sure that with Benefit Focus that we're reviewing that. And I'm also going to put, you'll see when you enroll this year, that you'll have to attest that you're still legally married. And if you get a board spouse plan, that you're still married to that person. So there will, quote, be reminders that you just have to acknowledge as you go through the enrollment process. So I'm hoping that will help us, and we have actually now with Benefit Focus, employees have to upload all this data. When they're married, they have to upload their tax document, which they don't normally understand, but, you know, you could still have a marriage certificate from, 30 years ago, but no longer be married to that person. So we require documentation of dependency, in one form or another, showing that they're still legally dependent upon that person in order to be eligible for health care. So yes, we've continued to, normally you don't want to do that more than every decade, to be honest, just because it had been about a decade since we've done it.
Thank you. And then my last question is, do we have any type of process, or have we looked at any type of process to incentivize those that have other health insurance that are using this as a secondary, or maybe using this as a primary and another one as a secondary? I know there's other organizations, specifically private organizations, that if you're on your husband's plan, that they'll give you a $100 bonus or whatever it is to not be on their plan. Have we looked at anything like that?
Through the years, there's been conversation about, you're talking about like an opt-out stipend.
Yes.
It's been several years since it's been discussed. There was a discussion about spousal surcharges, for spouses who are declining their coverage. With your rates, they're probably not doing that here as much as they might if you were subsidizing that even more. But, certainly it's an expense. The board it's free to the employee. So, for them to opt out to go to their spouse's plan would strictly be a plan design. I want to be in my family plan for any out-of-pocket expenses. But, it's definitely something to maybe talk about, but it hasn't been done here. We've seen a lot of groups go away from that strategy, particularly when, the ACA, or the Affordable Care Act, and the mandate for coverage and all those things happen. But so that's certainly something that could be discussed.
Yeah. And I certainly don't want to encourage anyone to opt out of having health insurance, period. I would just, if they have two plans that they're not paying for either one of them, or that, is there any way to incentivize them not to use ours, to use the other plan that they have access to, would be my.
And there is some administration behind that, because the district does have to report the offer of affordable coverage every year as part of their reporting to the government about making sure that their employees have other coverage. So there would be some administration in terms of an attestation. It's really kind of hard to prove 100%, but, with an affidavit or some other kind of attestation to say that I'm waiving out of this plan, but I do have affordable minimum essential coverage through my spouse's employer. It's something we could look at. Again, I think a lot have gone away from that, but some still do.
It's just the ACA has made it a little more cumbersome to be able to, explain that and really have people correctly attest, because we would have to have proof of that. The good news is with the Benefit Focus, we could create something like that now that we have the automation. But we'd want to make sure that we have that proof, because if we don't have that proof, then we face fines from the ACA if we're not able to prove.
And then the other thing is, the board is funding for all of those people today.
Yeah.
So, and let's just say you're at $814 a month or whatever, that we would still hope that there'd be some funding for that, because while you might be paying a stipend of $100 or whatever, you're also eliminating potentially in theory, $700 a month worth of revenue that's helping to, support the plan.
Right.
So there'd be a lot of considerations for it, but it has been looked at in the past, and we can certainly dust stuff, and come back if it's something that the board feels is a good thing to do.
Thank you.
Yeah. Okay, well, here's how we stack up among the top 10 school boards. And now this is, you only explain this percentage because it's just a financial exercise. What we'll look at later is actual plan design driving this. This is purely based on the employer and the employee dollars coming into the program. So it's not an exercise as looking at whose plan compares better or richer from one to the other. I will tell you the only school board on here that is fully insured is Hillsborough County. And they have to go out, because of that, they're going out like every 3 years, 2 or 3 years, which the exercise, that's a lot of work but they're fully insured, and they've continued to, their board and their superintendent has wanted to go in that direction. But as you see, they're number 3 behind Polk. Yes, ma'am.
We keep saying that's a lot of work. It's a lot of
It is.
It's a lot of expense to employees. I'd
Sure.
be interested in what they're doing to be able to manage that at that size county.
Yeah,
And I can talk to colleagues in Hillsborough on the board. I would just be curious,
yeah.
in your conversation, that has to be beneficial to them for them to keep working in that
Well,
capacity.
sometimes it's a political decision. I was with a district in my past that had done that because they had ended up, having to pay back money to their insurer, and they just got to the point where they said, it's an expense, Linda, we just want to pay it and walk away, because there's no concern with run out. Managing your program, you're typically buying a set of benefits, and then you're offering that. I know over the years, I say a lot of work, Ms. Miller, but they do end up with tweaks every time they go out to bid, obviously, and as expenses go up, to try to cut back on costs. So they've got changes in their premiums and changes in their plan designs, which, I say a lot of work for the department, but it's also a lot of following up with the employees, right?
Yeah.
Oh, what is it today? Because I can't keep
Right.
track of what my benefit is, so. But it could be more of a, as some of their history with, with their grant way back when, and they ended up at a significant loss and are still struggling.
Well,
You
I can
know,
tell you
so.
because I work with a lot of public sector employers, large. In the RFPs that we do, we very rarely ever get fully insured proposals. And when we do, they're not competitive. And that's really because, as we said earlier, 95 cents is going to claims dollars. And if let's just say Aetna was looking at your experience and looking at what's going, they're not going to buy a $14 million loss. They're not going to come in with a premium in any case are going to ever come in. And if they do, it's usually a one-year deal. So there is, it happens periodically that an insurance carrier will underwrite it and say, hey, we can save you $10 million, go fully insured. And then next year, when they lost $14 million, you have a 30% rate increase. I'm being kind of, exaggerating a little bit on that. But, your claims dollars are your claims. They're your claims and they're your risk at this point. The days of carriers wanting to come in and take that risk off your plate, they're not looking for losses. That makes it very difficult for them to stay in business, quite frankly. And this was another thing that the Affordable Care Act did, is they did mandate how much has to go to claims versus administration. You're already well below that. For a group your size, it's 15%. So here's the pie. No more than 15% could go to basically administration of the plan. And when you're fully insured, you have 2 to 3% state taxes, insurance taxes that are already right off the top. So, let's just say $1.2 million for every 1%. You're already paying, $2 to $3 million just in state taxes for that. But the bigger risk is really just your claims. So it's very rarely, and when we do put these RFPs out on the street, we will generally ask for a fully insured option. Because why not ask? All they can say is, no, we're not going to do that, or we're going to put in a proposal that's so untenable that you wouldn't do that, because it's, as opposed to $30 million, it's $162 million. And that's not something that would make any sense. So, but certainly, Hillsborough, and it's still kind of baffling to me, that they've been with Humana for many, many years, and they have been able to maintain that fully insured plan for many, many years. So I don't know that anybody would come into Polk County with, the composition of the medical community and just the costs associated with care and lack of sometimes competition, that we would get anybody that would make a fully insured. Last time we did the RFP, we did ask for fully insured proposals and didn't get any here. So, but never hurts to ask.
So you see, it's really kind of pretty close in the middle of this until you get down to Duval, which is at 82%, 18% to the employees. Palm Beach, 79-21. They've done some pretty aggressive things down there. Pinellas, 79-21. Miami-Dade is a little misleading. They have salary bands, so depending on what the employee makes is what they pay. So they have bands that they have been able to administer over the years. So it's complex, but they actually charge. Their philosophy is they charge less actually for the lower paying employees. So that's why they happen to be a little lower on the bottom. It's probably not quite 75%. That's overall what we came up with. Now what we've done is we've taken a plan. We got some plan design information. Jan's firm does a yearly analysis of a lot of large employers, but we actually went out and we got a couple updates to this that Jan will talk about. But we actually have, as you see, Polk is the only one. We're in the front here with one plan. You're going to see we took what their plan was similar to ours, as similar as possible.
As close as possible.
As close as possible. Again, they're not all an exact match, but to kind of come up with, we thought the cost was in the plan designs. This gives you an idea overall that Broward and Duval both have a zero-cost plan that they're offering to their employees. And you'll see the spouse charge there for that particular plan. And you see our children rates depending upon what's 1, 2, or 3. And then you'll see that, again, this is a function more of everybody having more of a 3 or 4 tier rate structure for their rates for their employees. And you see the family costs range anywhere from $699 to $839 for us, and you'll see where that is across the board. As I said, Palm Beach has done some pretty aggressive. You'll see that the premium in Palm Beach is reduced, and as well as Osceola, for any wellness activities. So there's a tie to wellness activities, which really is creative as far as getting employees engaged in their health care, understanding their numbers, understanding their cholesterol, understanding their weight, blood pressure. And I know in Palm Beach, because I was there for a number of years, that you were allowed to miss one. So you could pick one you knew you'd never make. And then you would have to make at least the rest of them or take some action, right? And then it would be the future year you'd actually get a credit. So you'd still get your plan for free, but it's getting you involved in understanding your health and where you were, and actually doing something about it, because then it became competitive in the next year. Okay, what are you going to do to lower? Are you going to try to lower something else? You got to keep the others under control. So it did become somewhat competitive and interesting, but that's where I said the staff at Palm Beach were used to pretty much roll out these district-wide programs with having wellness people in the schools to actually help deliver that content. And be it competitions, be it, focusing on this or that, they saw success over a number of years holding down their rates and actually getting people more engaged in their health. And, it took time for some people, 3-5 years, but people got more engaged in their health, and they understood that they were going to pay more for health insurance if they did not meet the criteria. So, and Osceola's, I think, is pretty similar to that as well, where they track that. And you'll see that the Employee Health Center, I'm sorry, go ahead, Dr. Allen.
On your matrix, for example, Broward, you have blanks and
Yeah, I was
as it
just
relates
gonna
to
explain
spouse, children, is there a zero there, or that they're just not even offering that option?
No, let me explain that.
Yeah.
This is a three-tiered premium structure. So you have employee only, employee plus one, which could be a spouse or
I see.
child, and you have employee plus two or more. So for instance, if the employee's free, but if they have one child on the plan, they're paying $696 a month for that plan. Your one child's paying $105, up to $245 if you had three or more children.
Yeah.
So, and then the family, my God, there's a giant fly after me. The family is, again, it's built up based on, do you have one child, two children, three or more children? The family rate ranges from $699, which would be you, your spouse, and one child. And then there's a middle tier if you have two children. And then there's the highest tier, which would be a full family of three or more children, is $839. So you can see that Broward, while they're taking care of the employee from an employee-only perspective, they don't have more than likely an awful lot of participation
That's what I was
of
curious
family members
about.
on their plans, because they do have three plan options, and they're all 3-0 to the employee.
Yeah.
The spouse, and, I mean, the plus one and the plus two or more rate changes, based on what's the richer plan. They must like my perfume or something. This little fly is after me.
It was over here with me earlier. I don't know why it's
Oh.
over there now.
So, for instance, Hillsborough, they've got 5 plan options at Hillsborough, and as we said, they're fully insured. The plan that we thought was probably closest to you, which was the national PPO plan, the employee-only rate, it did go up 6% since this was published, so it's now $71 instead of $67. But they also have an employee plus one rate, so that's going up to $688 for 2023. And then for the two or more, it's going up to $1,086 for 2023. I skipped over Duval. They actually did implement an HMO plan at Duval, and for the first year that they rolled it out, it was the only plan available to a new hire. So if you were a new hire on Duval, at Duval schools, your only plan option was the HMO plan, which again was a pretty all-in network, scaled down, plan option. They have Blue Cross Blue Shield of Florida, but Blue Cross doesn't really have that plan here, per se, in Polk County. So they have 0, their rates are going up 8 or 9%. So that second tier, the spouse rate's going up to $433. The child rate, and again, so what happens in a 4-tiered plan is it doesn't matter if you have one child or 5 kids in that plan, it's all a blended rate that covers the costs of however many kids are in there. So if it's, an employee, an employee plus one child, they're paying $311 a month for that. If it's an employee and 5 kids, they're paying $311 for that. And then the family plan that's comprised of a spouse and 1 or more children. So the 4 tiers are employee only, employee plus spouse, so you don't have any kids on the plan, employee plus children, you don't have a spouse on the plan, and that's a more expensive tier for the spouse because spouses' costs are higher than children costs. So when you look at the spouse rate is $399, it's going up to $433, the kid rate's $311, so the kids are a less expensive risk to the plan. And then the family tier, which is the 4th tier, is a spouse and 1 or more children. So, and then Orange has a 4-tier. They also have 4 options, but you can kind of see, again, when you kind of go across that children rate, not to pick on that, but, and even with Orange with the spouse rate, it's $826 for the spouse versus, $594, and then the family tier is $1,110. And it did not appear that they are making any premium changes to their plan as of January 1 of 2023. And then Linda mentioned Osceola. They really have 2 plans, but within those 2 plans, there's a way to buy down your premium if you do wellness activities. So you can, that $42 premium could be 0 if you do all the wellness activities. So, but if you don't engage in the wellness, you don't have to. It's just that you're going to have a $42 premium a month for not engaging. And within their plans, they have a good, better, best network within that. So, you know, basically, the very narrow network that they have, which you have to go through a navigator to use, that has the best benefit levels. So the lower co-payments, the lower cost share, if you will. If you just go to a good, you can still do that, but you're going to pay more when you go to that good doctor versus the better doctor versus the best doctor or healthcare facility. So they've got a fairly unique structure to theirs. So within that, they have the two different programs. Within those two programs, they have those three levels of provider choices, if you will, and then they also have the ability to buy down the premium. So their buy-up plan, though, is not free. That one's not free. So they can buy it down to a lower premium, but it's not a free premium. And then Palm Beach has three. So Palm Beach basically doesn't have a free option for employees. The plan that we thought was as similar, close to yours, which is an in-network only plan, this one does not have out-of-network benefits, is $90 a month premium for that plan, and you can see where the other tiers fall within that. And then Pinellas has 4 plan options, and the plan that we thought was most closely resembling your plan, that has a fairly hefty premium associated with that. They do have other plans that are available that are very narrow, very much more limited, that are lower cost. They're not free. They don't have a free plan option, but this one was the one we thought most closely, resembled your plan.
And Palm Beach has a similar option as to what Duval just went to, with offering only one plan selection for new hires, with the idea being that when you came on, you had to be on there for a year. And for some folks, that meant almost 2 years, depending on their hire date, before they could have the option of choosing between the two. The idea was to try to get people to try the lower option program, rather than just, people sometimes will defer to the higher option because they don't want to shift the risk over to themselves. They'd rather shift it over to the employer. But, sometimes they'd be like, well, did you try the other plan? Well, year by year, it's a guesswork as to what you think your healthcare expenses are going to be.
This
So-
year, for open enrollment for 2023, Duval is opening up the HMO if somebody wants to choose that plan.
Yeah.
Versus the non-contributory plan that's shown here. So those are going to be available for people to enroll in starting next year. Any questions on these are the employee contribution comparisons? Yes.
Your conversation there just triggered a thought going back to the claim cost, where you're doing you were talking about the 4-tiered and the strategy considerations. And if we look at the employee cost to us in regards to claim cost, that's the one. So do we have a breakdown of what group, say 1 to 5, 5 to 10, 10 to 15, as far as years of service, where we're seeing the higher claim amount on the employee only? Because if we look at the breakdown here, the employee sections obviously are highest as far as claim cost. The lowest claim cost is the children tier at $230. If you look at, roughly 3,000 count at the cost there, is probably the lowest claim cost perspective-wise. So any data on looking at that? As far as looking at the employee
Tenure on towards,
well, let's just say, okay, because that's our highest claim cost, right?
for this.
Based on your metric here, you're looking at $7.5 million per year approximately, based on the count and what that claim cost is. So I think my question is, do we see, 0 to 5-year employees, that's where the higher claim cost is really coming? Or is it, And that, the variable's hard because they're gonna change as well. So, maybe you have somebody come in as a single member, 0 to 5, and maybe they change, to married, and now they have a spouse, they've added that to their plan. I mean, there's a lot of changes that could take place there. So when you were saying, Ms. King, about, when a new employee came in, they only had that one option, right? So if we're saying that we have a higher cost in that 0 to 5 years in regards to claim cost, is there any benefit to only then moving them into one particular option?
Well, I think the incentive, I haven't talked to Jackie in Duval to see what her incentive was behind doing that, but I know in Palm Beach, their incentive was to get people, they were convinced that there were people that were on the, higher option that were just like in that over 40 group and were just concerned about the amount of money should they have to lay out, should they have expenses that year, right? But every year, we know really what we end up expending, what comes our way, basically, can change. We know theoretically as we age, as our disease state progresses, because you've got a lot of variation in there, right, with when you're hiring a young person, are they a diabetic already? Well, your cost right there automatically is going to be higher, depending upon, the actual disease state of the employee. I mean, we know obesity is driving our rates considerably, and those people that are going to be coming up on those additional medical costs as they age, unless we're able to tackle that and get that down. So there's a lot of variation there, but no, I have not looked at by service state, to be honest, trying to drive that. I have to work with SAP to see if we can even
I don't
drive
think
that, but.
Well, because it's the claim system,
Sure.
so we,
Yeah.
Florida Blue administers the plan. They get eligibility files every week from the district.
Yeah.
I don't even think that, that could be a field that's included in the eligibility, but the algorithm to try to get back to,
Yeah.
a data higher and, a claims expense
Yep.
is probably going to be very, difficult to do. Now, I will say, another strategy or reason for kind of limiting to maybe a lower cost plan is if you have a high turnover rate.
Correct.
So, someone who works for the district for 3 months and then doesn't work out, now they have a major claim problem, but they COBRA, they take their continuation of benefits coverage, is going to be at a plan that's not the richest potential
Yeah.
plan.
Also, there's other strategies that play into that, like getting more to a medical home. I hear a number of successes when we do get people tied to more of it. It's going back to more of traditional healthcare with using a primary care physician. And I'm surprised at the number of young people that don't really have a primary care, which we try to get them introduced to the center and maybe using that as their primary care. But going back to a medical home kind of way of managing your overall care, is another way of looking at helping to control costs and preventative claims, trying to get ahead of different disease states, trying to catch things early, so to speak, before they become a problem, has been another strategy that it's going back to more the old way of doing medicine, to be honest, more the way we used to do it. But a lot of people don't do that. Some families do once they have children, but primarily they don't really do that in their younger days. We see them just going, like a female may just go for an OBGYN visit and use that OBGYN for their sinus infection. I've heard employees tell me this, and I'm like, well, how do they really understand what your need may be? I just try to talk to them to understand really what's driving, that generation's way they obtain care. So, but I think using the medical home process is one way to help us hopefully get ahead of that by offering that free service. I think it makes it attractive for even every socioeconomic group in Polk to be getting ahead of their conditions, or are they, looking at those metrics, which we do have Everside look at that for us, to see how many people, where are our deficits? Are we having everybody do their pap smears? What are those criteria for those wellness incentives, and where are we as a group? What areas do we need to focus on to make sure that we're getting ahead? Catching cancers early is a lot cheaper than catching them You know, we're seeing more and more young people, to be honest, with, you know, with colon cancer and other concerns in their 30s, which is very concerning. So we did away with an age restriction on that. We have free, you know, the little colon guy, the little box. I'm trying to
Cologuard.
remember his name. but-
Cologuard.
Cologuard, thank you. That, you know, you can get done for free through the health center, you know, and have you at least explored that depending on your family history. You know, everybody's eligible for that unless you have a history in your family, but trying to get ahead of that. We hear success stories all the time from people that do use the center and are able to get answers to something and get ahead of something. So the more and more we can encourage that. We are expanding the health center. We're adding those 10 additional beds that we're opening in the expansion. We hope to be open in January. We're hoping that will help us serve more employees, so.
And there's been a general shortage of primary care, quite frankly. In certain areas, there, you know, provider deserts, you know, healthcare deserts where you can't really
Yeah.
get the care there. So
Yeah.
coming into, you know, to the health centers is hopefully something that people can take advantage of. And, you know, we've talked to Everside, actually through the years, of how do we take care out to some of those areas. You know, kind of a hub and spoke kind of a thing, where the hubs are the facilities, but then you've got these little satellite spokes, if you will, in different areas where you might have a shortage of good screening tools and healthcare services. So, you know, there's a lot of opportunity. It just, you know, and then in some respects, just some people, no matter what you do, they're just not going to feel comfortable using the healthcare system. You know, I'm not going to see a doctor. Maybe I'm afraid of what I might hear, or I just don't trust the healthcare system for a variety of reasons. About 28% of your people aren't using any healthcare services. So, I mean, that's alarming, really, when you think about how someone might have a real treatable condition going on, and then they're not seeking healthcare services.
I do hear that as well. I hear that people say, well, have you done this? Oh, no, I don't want to know. I'd prefer, which I'm, you know, somewhat surprised, but, you know, some of that's cultural, I think, you know, and some of
Yeah.
it could be just, you know, personal experience.
So the next page is really kind of a plan design comparison, because it, you know, your health care expense is made up of what you pay out of your pocket in premiums, and then also what you pay out of your pocket when you use healthcare services. So, so this one is talking about what the deductibles and the coinsurances and the out-of-pocket maximums are. So again, it's the same districts that we were just looking at. You know, we talked about in-network and out-of-network benefits, so that's that first line. If it says yes, you can go in or out of the network. If it says no, you're restricted, but for an emergency, to using a set of providers. Next is the individual deductible, and that generally is double if you have a family. So you either have self-only coverage or you have family coverage. Any dependents is usually double. So you're $900, that's $1,800 if you have a dependent on your plan. So you can kind of see your deductible is already kind of up there. But again, this is one option versus this is one option of multiple options for these other companies, for these other districts. So when I mentioned about Osceola in their plan, the lowest deductible you can get to is $900 if you use that best. But if you use the good, it's going to be a $1,250. And then there's a better in the middle, if you will. So, so you can kind of see where the deductibles stack up. You do have a separate prescription drug deductible that has to be met, of $50. That Palm Beach has $100, but that's not something that some of the other districts are doing at this point. Coinsurance, you're at 20%. You can kind of see where the other groups are. That's the percentage of the allowed amount that you're going to be responsible to pay when you use an in-network provider. These are all assumed using an in-network provider as opposed to going to an out-of-network provider if that's available. And then the out-of-pocket maximum, so in any given plan year, this is how much you would be responsible for covered health care services out of your pocket in the year. And then primary care or specialist copayment, that's how much you pay, but for preventive. Preventive covers at 100%. So if you're going for your annual physical or you're going, that's covered at 100%. Yours is $50 or $50, whether it's primary care or specialist, and you can kind of see how the other districts cover the primary care versus specialist co-payments. Hospitalization, deductible coinsurance. You can see Hillsborough has a deductible plus $500 a day up to 5 days. So that, there's a pretty significant cost share there. Pinellas also $500 a day up to 5 days. Your average length of stay is less than 5 days, so, you know, that's been a fairly, you know, particularly with co-payment plans, that you trying to stay with a co-payment concept would be a co-payment for every day that you're in the hospital up to a maximum amount. You can see where the ER, emergency room, emergency department services, you can see how you stack up your deductible and coinsurance, so $900 and then 20% coinsurance. If you're admitted, it's waived. So you can see how all of that, and Pinellas is, so I think it's deductible plus coinsurance, but I need to look, I've got it with me. I'll look at that. I don't know why that's blank. And then, again, we look at prescription drugs. So generic is usually the cheap, you know, and you've got over a 90% generic dispensing rate. So people who can take a generic are taking generics. And it's $8 basically for a 30-day supply. And $20, so 2.5 times copayment for your 90-day supply. And you can see how that compares to other districts. And then you have the preferred brand. Those are the drugs that are rebatable drugs, that are the basically tier 2 drugs, if you will. They're preferred brands. You can see that right now you've got a copayment plus 10% coinsurance up to a maximum of $80 for a retail, and a flat $125 copayment for a 90-day supply for the preferred brands. For non-preferred, it's $80 plus 10% coinsurance to a cap of $160. One of the things we put in a schematic, if you will, of a plan design structure, which was the base plan buy-up plan, and some minor plan design modifications, was to simplify this prescription drug benefit and take those 10% coinsurances out. That makes it very, it makes it less predictable when you go to the pharmacy, how much it's gonna cost you. You almost just have to budget, well, it's gonna be $80 or, you know, maximum, but you don't really know what it's going to be until you stand at the pharmacy counter and they tell you what your cost share is gonna be. And then specialty, which are those biologics, multiple sclerosis, rheumatoid arthritis, some of those, your number one drug is Humira, which is everybody's number one drug for rheumatoid and anti-inflammatory conditions. Preferred is $80. The average price is over $5,000 for a 30-day supply of that, by the way. And they are limited to a 30-day supply. Broward, it says whatever the applicable tier is, so you can kind of go across and see. And again, these are rare conditions, so they're not, you don't have a lot of people taking these very expensive medications, but they're people that really need to take these medications so that they don't have other complications of managing their conditions. So, so that's kind of how Polk compares. And, I had a spreadsheet this big that's got all their plans, but I couldn't figure out a way to make it, boil it down into something that, we'd be able to do. But if you want that information, I can certainly provide that. Okay.
We were struggling with how to summarize that.
Yeah, I was like, oh my goodness, I don't know.
It's really kind of hard looking at this. When you say there's 2 plans, 3 plans, 5 plans with, let's say, and then you said the one that's closest to ours, but yet it doesn't do this, but it doesn't add that, but it increased it. So this is really, and I studied this sheet, and I still am like, I don't know that
It's difficult.
I understand it that much more than I did when I first looked at it this weekend. So
Yes.
if maybe that might be clearer, if you wouldn't mind
Oh,
sending
I don't
it
mind
to the
setting,
board,
I
that would be
don't
great.
mind setting that at all. It's,
Yeah.
again,
Sure.
Big
It's a
spreadsheet,
monster,
but at least it'll show, like, here's all 5 plans
That's
for
right.
Hillsborough, and,
That's right.
and below will be the premiums for each one of those plans.
Exactly.
So you can kind of see what the cost share is when you use the plan, and how much it costs you to buy that plan, so.
And just for information, we did have, Kay, correct me if I'm wrong, we did have a flexible medical, if you remember that. And then, once we voted on it after the employees spoke and all that, then the union got upset with us and took us to impact, I mean, it was holy hell. And here we thought we were giving employees the opportunity to have what we would call it, and again, I'm dating myself, cafeteria
Oh, I was here
benefits.
too. I was
Were
here
you?
too.
You remember that? I mean, I was
Sure.
like, seriously, this is what the employees want, and all your people are calling us, telling us, we vote for it, and then we boom, the next day. So I think having, I call it cafeteria benefits, you call it, I don't know. That's why I'd love to see what all you actually looked at. Not that we're gonna have to copy an individual one, but it would be helpful to understand these numbers, because they're not really in context.
It's hard to compare.
It is. It is.
And there are other considerations beyond what you see on
Of
here.
course.
Your medical,
course.
the medical community and
Sure,
the players on the Blue Cross, Aetna, United,
So,
on that
so are
side.
you gonna come back to us with maybe after doing all of this and say, hey, you can forego that email if you're telling us we're gonna come back with perhaps 3 different options to
Well,
present? I
what we
don't know.
wanted to do, that's why part of our summary at the end was really just wanting direction on what, you have told us already that you're looking for some additional information, right? In a number of these areas, so that was kind of the purpose of today, was
Okay.
to come back and get, bring you more information and kind of get some direction. I mean, understanding that, we have to bargain everything, but kind of getting an idea and kind of updating on where we were strategically, just because of the financial concerns going forward, and to allow us time for planning and other strategies as well. And to be honest, we have taken, Jan talked about the plan options, we've had discussions with your insurance committee, superintendent's insurance committee, on a number of these things. We've talked about some of these proposals. We'll be bringing back more things to them so that we get some discussion with the union. And I remember historically, Jen's filled me in on some of that. And to be honest, I mean, it's all understanding the plan and understanding, coupons. And, we had the union had some concerns with how to do coupons. And we understand that there's a lot of educational gap, right? With the more and more we would be looking at changing things. How do we get out ahead of this and educate our employees? With Benefit Focus, we do have an online guide and everything in there, and we've been working, we will be going out again this fall during open enrollment, and give people the opportunity to come and meet with us. We are providing, we did new hire orientation. We had great turnout at PEA orientation, a number of people that didn't understand their benefits, that just wanted to come in and sit down with us. So that was very successful. And just kind of leading them through the technology and showing them how simple it is to be able to access information about how the health plan works, dental plan, vision plan, understanding some of those nuances. With the online platform that you did approve, we are able to deliver that information 24/7 now out to people, instead of having to hunt all over for a piece of paper. So that has been very helpful. Yes, ma'am.
When are you looking to go out for the RFP? I know you said in '23 for '24. What
Yes.
is your target timeframe, Romaine?
Early,
Early.
probably January-ish,
Okay,
is probably what we would be looking at.
thank you.
You're
And
looking
again-
typically at like a 6-month process, right? Because we need to have committees, we need to, see what we get and talk through, some of the options as well. And then, because to be honest, the planning lead on open enrollment, I have to normally have everything updated in Benefit Focus and rates and instructions to them by like September, in order to get all that programmed in time to normally roll out. And I mean, depending upon what we do strategically, we could push back open enrollment a little bit. Employees still are used to it happening in October, so I've kind of left it there for now. But we could push it back a little bit depending upon when we start deductions and how quickly we can get the file and automation. But we do need additional time to plan, so all of that goes into that January effective date, so.
So what are you all needing from us?
Excuse me?
What are you all needing from us today?
Well, you've asked us for some additional information that we need to take back and pull together from you. And, you know, from that, we need to finalize recommendations, I guess, from you all. We need to go to union negotiations with some of this, and then obviously implement strategy. But a lot of this, it sounds like there's a lot of more detailed questions on each aspect of the program, which I agree is definitely something that we should look at to see how effective some of these things are that we're doing. And it is a myriad. We're seeing that in every district. Never was it all these pieces that, you know, and how do you learn about every piece to your benefits so that when you need it, you can remember, oh yeah, there's that outpatient surgery benefit. I need to remember to call there. And a lot of employers are going to more navigation, which is a navigator that they would call and get help with when they have questions. So that's certainly a strategy we have talked about as well, because the more complex benefit administration gets and plan offerings, the more it helps the employee to have access to find out, oh, where could I go for this, or where would I go for that, for questions. So not only the online platform, but also maybe a human person that they could talk to. So I've got some notes as far as what it sounds like you all want. Jan and I have been making notes, so could certainly come back and we could talk to, you know, leadership as far as timing on all of that and bring that back to you, and then we could go forward one there as far as recommendations or some things you would, you know, like I said, these things I'm more vetting also through the Superintendent's Insurance Committee, just so they understand and I can ask questions about these initiatives. One of the things, I don't know that we missed it during the diabetic program too, there's a number of different offerings out there now. There's Verta Health is working with the United States government, Department of Defense on eliminating and reversing type 2 diabetes. Is it for everybody? Probably not. So, but it's just one more thought process as far as they've shown some pretty good success, but it's focused on more very intensive coaching, more of a keto focus as far as eating, and they do kind of take over medications. It's been interesting. Is it going to be successful? A number of us at school boards are looking at it as a potential offering. There's a zero cost. All the money is at risk, basically for the cost for that program if it's not successful. So Livongo is another term out there for diabetic management that's, I know Orange County is using that. So there's a lot of these initiatives, Verta, I've brought to the SIC to take a look at. So just trying to vet these things to allow the union members to ask questions and take a look at some of these things too as potential offerings. So. Additional questions or?
I mean, the ABCs of Diabetes program, what is your feeling about changing that incentive around? Is that something you would support potentially? Obviously, the numbers need to be right, but is that, or does it feel like the advantage of having that incentive the way it is today would outweigh savings?
Can you repeat that, because you're not clear?
Oh, I'm sorry. The ABCs of Diabetes program, one of the things that we discussed is looking at the incentive today, the way that it's structured. And I guess I was just soliciting feedback to say, is that something that, as a board, you would support making potential changes to that incentive to maybe put a little bit more back on that ABC's participant to still have an incentive, but maybe not free as an incentive?
Okay.
I would like to see the numbers of we don't know how many participants we have. It's,
600-ish.
600,
You have
yeah.
about 600.
That's about 600.
have we gotten feedback from, I would like to get more information from the people using the system. I don't know anybody that uses that program.
Does that
I've
include
had
retirees?
some good feedback on it, and then I've got people that are also checking a box. And I think when you say feedback about the program, I think also the providers at Everside would be a good source of some, both pro and con. Because sometimes I see where if they just check the box, if we're not really outcome-based, then are we really making a difference? Are we moving the needle, so to speak, for that person? Some people have had great success with it and are approving their A1C, but not everyone. So it's a checkbox. So if they're not getting any better, but we're continuing to expend all those resources, then, and we've talked at nauseum, to be honest, with Everside and Prime about how do we do an outcome-based? How do we really drive something where we're, if the employee needs mental health help, are we making sure that they're engaged? Is it mental health that's in the way of them improving? How do you really dive down to really find out how you make this truly outcome-based and still continue to offer an incentive, so to speak? But even free, to be honest, is just becoming, we'll bring you back the total dollars. The initial estimate I had was maybe about $2 million for over 600 people, which is a cost. We would also have to look at how much that helps us avoid, right? Because there's a plus to managing the program, where it could end up being much more expensive if we don't. So we can bring back those details to you, but I think it's important to hear from every side as well as some of the employee testimonials as well. Mrs. Miller, Ms. Cunningham, I'm sorry.
Yeah, I was just going to say, being a member of that ABC of diabetes for a number of years, and I think you and I have had this conversation.
Yeah.
I'm all about asking the individual to take part in it. My numbers have come down significantly because of the education and the knowledge that I received, because I keep in touch with my healthcare provider through our school board health clinic in Haines City. My coach, she's fabulous, Ashley. I mean, when you're trying to deal with a disease, is what I call it, you do need all the help that you can get. But you
Yes.
know what? In the end, you've got to have some skin in the game. Is that probably the best way to put it? And so with getting that information, you have to take it upon yourself to do something about it. I've been blessed, and I have done that, and I'm very grateful. So, yes, I would be in favor to look at restructuring, or whatever the words are, but I just don't want those of us that have worked so hard to be penalized and maybe not provide an opportunity for somebody else to get the knowledge. If they don't take the knowledge that they're given and they don't improve, that's quite frankly on them. But for those that truly need it and need to learn from it, I think the opportunity needs to be there. How you structure it, whether you go down and you look at your A1C, your blood pressure, your, all the different pieces that we look at when we get our blood work. And yeah, you have to see those numbers getting in range. I mean, praise the Lord, I'm in better health now at my age than I was 20 years ago. So, but that comes from having the opportunity to be educated, taking those options, and then making the difference in your own personal choices.
Yes.
That's really where I'm at. So I may be the only one on here left that has been part of the diabetes program. But anyways, I think we should have the opportunity to relook at it, of course, because I think it's huge. So thank you for all that y'all have done to enable me to make steps to better health. So,
Congratulations.
thank
Yes,
you.
yes.
It's
You
been
want to do a
amazing.
testimonial? I think we
It's
should
been amazing
videotape that.
how
and,
how far my numbers have come down
Yeah.
in everything. I had a,
So, Madam Chair?
Yeah.
I know you had a question, and then I wanted to make a comment, because there's been a lot of information that has been provided to the board, and the next steps seem to be pretty broad and are going to take a little more time. So I think there's specific questions that the board members may have that they may want to submit, and then in terms of finalizing recommendations, I think there's more detailed information, the specific questions that they would want answered. And then maybe in terms of recommendations, multiple recommendations coming back to the board so that they can analyze that and ask more questions before we get to the point where we're talking about union negotiations and strategic implementation. But I do know that there are a lot of questions, and Madam Chair, I know you had a question.
No, that was a great segue, because I was kind of going to go in the same direction of, I am sure that we could probably sit here until at least 7 or 8 o'clock tonight to ask a million questions. And I'm happy if anybody else has a few that they want answers to today, but if we could submit questions to Superintendent Hyde and copy Wendy on them, and then that way we can get them to you all to get answered, because I'm sure it's a lot to digest. So I'm sure as we're laying in bed thinking about how we're going to solve all the world's problems, even more questions will come up.
Yes.
But so if all of those we could submit to Wendy, or to Fred and copy Wendy in the next week or so, that would be, I think, helpful, especially for you all to have them all in one place.
That'd be great.
My other just kind of comments was, you talked a little bit about negotiations, and I would love to see us looking at if there's any ideas that some of our staff members have that are actually taking part in the benefits. Or even, I don't know if we've talked to either of our unions and kind of what in their circles, if there's cool ideas being proposed in other places that their colleagues are talking about. I would love to be on the front end of getting that and make sure that they're a part of the conversation moving forward.
That'd be great, thank you. Mrs. Fields?
My comments were similar to Ms. Wyatt. I know the value of the ABC program because my sister, who is a retiree, really utilizes it and speaks highly of it. So that's why I wanted to know how many employees are participating. I already asked that question, and the retirees. And I think that we need to get feedback from them as to what they would like to see in the program that they might not be seeing now, and what they might not be using that might need to go away. I think getting input from the folks that's using it would be very important.
Thank you.
So,
Ms. Fields.
Madam Chair, again, so I think we're all saying the same thing. I think it's an opportunity for the board to submit specific questions back to you, and then you collect that information, get some answers, then meet with the superintendent so that once you have an opportunity to meet with him, there may be multiple recommendations that come back to the board. Give them an opportunity to look over those recommendations, kind of analyze, ask questions. They may want you to go back, obviously being charged by the chair, Madam Chair, to go back and also get input from our multiple stakeholders, our collective bargaining unions and those things. So want to thank you, Madam, thank you for quite a bit of information. Madam Chair, that concludes our health plan renewal update.
Thank you, I appreciate it. And I will not do this, we won't sing on camera. However, I will ask you all to stick around for 2 minutes after our meeting because our good friend Jessica Hall is celebrating a birthday today, and she did not tell anyone until we were sitting at lunch, and she said, "I'm celebrating my birthday next week." I was like, "When's your birthday?" She's like, "Today." Didn't tell any of us. So we have some cupcakes. Linda ran across the street to Publix to get us some stuff to celebrate. So if you all don't mind just sticking around a couple minutes after we adjourn so that we can sing and celebrate Jessica and thank her for all that she does to keep us on air and alive. So thank you. And that will conclude this meeting.